Okay. I'd like to welcome everyone to this luncheon symposium. My name is Mark Menser. I'm the chair of the symposia and also CPD director for the Canadian Association of Emergency Physicians. I realize that many of you are currently in line just gathering your meal. We will still try to get started on time, but we'll give you another couple of minutes to gather your food and have a seat at one of the tables. Feel free to sit up closer up front. Sometimes the experience is a bit better. We will also ask you to fill in the evaluation forms. There's forms on your table, but there's also a evaluation form within the CAEP app, and we do want to know what you think of the program. It helps for designing the curriculum in future years. We have an excellent set of speakers here for you today, and they'll go through the individual introductions, but we have Dr. Mitchell, Dr. Stenstrom, Dr. Bell, and Dr. Ghosh, and they'll give you an excellent presentation that I'm looking forward to as well on anticoagulation use within the emergency department setting. So we'll give you another minute or two to gather your food, and then we'll get started. Thank you.
All right, guys, so in the interest of time and getting us out of here in true emerge fashion and in good time, I'm going to get started. My part is not that important, so feel free to keep collecting your meals and eating through it. I'm really here just to do some housekeeping and some introductions. The introductions part obviously is important for our faculty. Welcome. Thanks for coming. Thanks to CAEP for hosting. Big thanks to Dr. Mansour for actually taking the time to go through all the content and get us accreditation. Thanks to the faculty for being here as well. I know we've talked about anticoagulation over and over again, so it's always challenging to present something that is of value, that is of interest, and we feel that we've done that today, both with the faculty and with the content and the style that we're going to deliver. And so for that, we would need to hear your feedback. So please fill out the evaluations, provide us your feedback, so we can tailor edit as we need to for future educational programs. These are my faculty disclosures. This program itself has received financial support, both the educational grant as well as from BMS Pfizer Alliance. All the speakers and faculty have received an honorarium from CAEP supporting the program. The CAEP 2018 Scientific Planning Committee has mitigated potential bias by ensuring there was no industry development in the planning or education content. So the entire planning and content was done by the faculty you see up here and has been vetted through CAEP as well. We have to comply, so you're going to see 3 slide disclosures, both with the CCFP and the Royal College. And again, everything has been reviewed. The faculty I'm going to take 2 minutes to introduce. Dr. Ben Bell, who many of you probably already know from these programs, is an internist at North York General, has done a vast amount of work in the area of venous thromboembolism and has worked quite extensively Thrombosis Canada to produce knowledge translation tools and apps that even I use in a lot of my educational programs I talk about. Dr. Brent Mitchell, who all of you will love, if you haven't heard already, also doubles as a stand-up comedian, has a great collection of hats, is an electrophysiologist by training, and is part of the authors of the guidelines for atrial fibrillation, the Canadian guidelines. And Rob is Director of Research out at BC, has a lot of research experience and has particular interest in atrial fibrillation as well. And the two of them are going to tag team on some interesting concepts on atrial fibrillation with regards to the new guidelines and rate and rhythm control. So here are the objectives, which I've already gone through. We're going to improve acute and follow-up care of VTE in the ED, including some challenging cases, so not your bread and butter cases. We're going to examine the controversy of cardioversion versus rate control from an ED and cardiology perspective. There's always been some challenge with cardiology literature, not really translating to emerge patients, and also with regards to what the current guidelines are and how they will be changing. And lastly, we're going to compare different patient characteristics and the impact of the new DOAC therapies in the ED. So the agenda will be Dr. Ben Bell first, followed by Dr. Rob and Dr. Brent coming in as the heavyweight tag team champions. We'll close it up with panel discussions. We really do want to hear your questions. If you feel that this room is a little bit intimidating in terms of coming to the microphone, please feel free to send it in to hashtag CAEP2018 as well, and I can certainly field your questions from there for the panel. So without further ado, I'm going to go through these accreditation slides. Housekeeping, of course, please sign the attendance form. Please complete the sign-up sheets. We need to know how many people attended. It makes a big difference on the evals. And then lastly, please complete and leave your evals at the table. Without further ado, Dr. Bell, thank you.
Well, thank you, Indy, for the kind introduction. I'm going to talk to you today about venous thrombosis in the emergency department. These are my conflicts. I've spoken for all the companies that make the direct oral anticoagulant, so perhaps I'm equally biased. But I think my most important disclosure is my membership in Thrombosis Canada, and I would encourage all of you to please download the app if you don't already have it on your phone. It's available for all types of devices, free, updated frequently, I think very useful for clinical decision making at the point of care, and I would encourage also for you to speak to your learners about it as well, because I think it's very useful from a resident perspective as well. These slides have already been reviewed by Dr. Ghosh. This program was made possible by a grant from the BMS Pfizer Alliance. So today I'm going to talk predominantly about the acute management of venous thrombosis. I'm going to touch on some interesting topics, talk about superficial thrombophlebitis, thrombolysis in PE, and hopefully we'll have time to get through all of the slides. We're all, of course, familiar with the tried, tested, and true method of treating VTE, and that's a low molecular weight heparin bridge to warfarin. There's a lot of nuance that's gone into developing this pathway. It's been developed over many decades, and of course the low molecular weight heparin needs to be given for a minimum period of 5 days, irrespective of INR, and warfarin, of course, given concurrently and continued until a minimum duration of 3 months has elapsed, and perhaps longer. But I think there's been a lot of evolution in the literature lately. Guidelines have certainly changed and don't favor this treatment algorithm any longer, and we'll talk about the evidence as to why. So this is a brief case. A 42-year-old man who's overweight comes into the emergency room with chest pains. He's hypoxemic, heart rate's on the higher side, but everything else is essentially normal, including his x-ray. His D-dimer is positive. CT scan shows bilateral segmental pulmonary embolus. It's all over the place. You've got a good radiologist who specifically comments on a normal-sized, normal-appearing right ventricle. Your resident who saw the patient administers 200 units per kilo of dalteparin. And there's a bit of a teaching point there as well, by the way, that we're not dose capping the low molecular weight heparins here. So the resident gives the full dose of dalteparin. And I guess the first question is, perhaps by show of hands, who's going to refer this patient to the internist in the emerge? A few of you, sure. Think that person would benefit from admission? Who's going to discharge the patient home for follow-up in the internal medicine clinic, the anticoagulation clinic, the family physician's office? A few of you as well. I think that either decision is rational. When we think about risk stratifying patients who have pulmonary embolism, this is the classic algorithm that I think that we were all taught in residency, and this is from the European Guidelines on PE Management from back in 2008, so a decade ago. Hard to believe this is so old. But they classified patients into high and non-high risk of PE, and the ESC was essentially recommending that we admit around 50% of patients to hospital in the so-called intermediate risk category, defined by having a 30-day mortality between 3 and 15%, at least in the era when these trials were done. And that's defined by a patient who is hemodynamically stable, so no clinical shock, but has signs of RV dysfunction either by a positive BNP or on imaging, or who has a positive troponin. And so because of the mortality that's associated with this disease, the ESC was saying, well, I think we should probably admit these patients for observation. The ESC was saying that we can discharge patients who are at low risk of death from their PE, and that was characterized by patients who weren't in shock, who had no signs of RV dysfunction, and who had no evidence of myocardial injury, so their tropes were negative. Obviously, patients who have hemodynamic instability need to be admitted, and those patients, of course, need lysis treatment for their pulmonary embolus. But I think that there's more recent data that lets us do a little bit better than this. This is so crude. This is saying, well, does a patient have hypotension or not? And if they don't have hypotension, how does the RV look, and what's their troponin? We can do, I think, a lot better than biochemical and imaging findings, and that's been proven with the PESI score, and indeed the simplified PESI score. The simplified PESI score draws a clinical picture of the patient alone. What's their oxygen saturation? Are they tachycardic? Is there a history of cardiopulmonary disease? And it's very rapid to calculate. This is a screenshot from the Thrombosis Canada website that lets you kind of put in these clinical criteria. And the PESI score, without involving measurements of troponins, without involving measurements of BNPs, without looking at RV size, tells us what the clinical risk of this pulmonary embolism is. It's been derived and subsequently validated in tens of thousands of patients. It's safe to use, and I think that we should be using it, particularly in a system where we're extremely resource limited, and admissions to hospitals should be avoided if at all possible. Case in point, this particular young, healthy man who has an unprovoked pulmonary embolus with a moderate burden of disease, but is otherwise doing very well, not hypoxemic, he should, I think, safely be discharged home to follow up in the internal medicine clinic, in the hematology clinic with the family physician in a couple of days, of course, with anticoagulation. The ACCP, the guidelines, when they were last written back in 2012 on this particular issue, would support that decision, and it says specifically in patients who have low-risk PE, and you can risk stratify patients how you want. PESI is one example. The HISTA criteria is another example. But also your own clinical gestalt is very reasonable as well. But if you decide this patient has a low-risk PE, then the ACCP guidelines would say that patient should be treated at home and not in the hospital. Of course, most patients with DVT should be treated at home, with the exception perhaps being patients with phlegmasia or, very proximal DVT, whom you might consider catheter-directed thrombolysis for. So teaching point number one, to highlight, not all patients with pulmonary embolism need to be admitted, and in fact, 50% or more of them can and should be safely treated at home. And almost all patients with DVT should be treated in the outpatient setting. So, decision number two. This is a case of a PE in a young, healthy man. What are you going to prescribe for this patient? Continue low molecular weight heparin and start warfarin. Anybody? Nobody's going to use warfarin in the group? Nobody? I find that hard to believe. Is anyone going to use dabigatran after low molecular weight heparin? Edoxaban maybe? Apixaban, rivaroxaban, or any of the above? Well, the right answer is any of the above. How do we treat venous thrombosis in 2018? Well, there's the classic bridging method, low molecular weight heparin bridge to warfarin that we've already spoken of. There's a single agent approach, which in fact has been around forever in the form of low molecular weight heparin monotherapy, which remains the standard of care, in my opinion, for cancer-associated thrombosis, despite some recent evidence for the NOACs. But of course, more recently, rivaroxaban and apixaban are both approved for the use of a single-agent approach for treatment of acute VTE. No need for injections whatsoever. If you want to use dabigatran or edoxaban to treat it, you can, but those agents require a 5 to 10-day low molecular weight heparin lead-in first on the basis of trial design. The NOAC approach is safe and effective. It's been tested in many trials, all published in the New England Journal of Medicine between 2009 and 2013, in all randomizing more than 27,000 patients. And this is the bottom line from those trials. These agents are all Health Canada approved, and compared to a traditional anticoagulant course with warfarin, they all demonstrate the same efficacy. So we're not losing anything by using these agents. However, in the case of rivaroxaban, we're seeing less major bleeds. In the case of edoxaban, we're seeing less clinically significant bleeds. In the case of apixaban, we're seeing less of actually both of those outcomes. Additionally, with rivaroxaban and apixaban, there's no need for any injections, so it's fully oral therapy. And so the bottom line is, from this, same efficacy as a traditional anticoagulant course with less bleeding. And so in 2016, when CHEST updated their guidelines on the treatment of VTE, they said that apixaban, rivaroxaban, edoxaban, or dabigatran should be used in preference to a vitamin K antagonist on the basis of this data. So my own starting point when I see a patient with venous thrombosis is use a direct oral anticoagulant unless there are mitigating factors. What are some caveats about using the NOACs in this situation? I would say that in the trials, most of the patients had normal renal function, were under 75 years of age, and were of average body weight. There were very few patients in these trials with cancer and no patients with thrombosis at unusual sites. However, that all being said, when I see a patient in whom I'm worried about drug levels, the elderly person who weighs 50 kilos, whose creatinine clearance is 30 mils per minute, I might think about using an agent that's based upon weight and can be measured, so a low molecular weight heparin bridge to warfarin. But if I'm seeing the otherwise healthy 80-year-old person, perhaps with mild renal insufficiency even, I still feel very comfortable using the direct oral anticoagulants in this situation. And indeed, subgroup analyses from all of these trials really haven't found any significant negative outcomes, even in patients whom I still do worry about. I would say that I tend not to use the direct oral anticoagulants in patients who are over 120 kilograms, but there is some evidence that's developing in that area. So, teaching point number 2, apixaban and rivaroxaban are Health Canada approved agents for the treatment of acute venous thrombosis and don't require injections. Those agents are safer and are just as effective. The guidelines for that reason recommend these agents in preference to a traditional anticoagulant course for the treatment of acute VTE. So let's change the case a little bit. It's a 42-year-old man who's coming to the emerge with pleuritic chest pain, but this time he's definitely hypoxemic, he's tachycardic, but his blood pressure is normal. He's got a positive troponin, he has extensive bilateral PE, his RV is enlarged. So I think we would all agree this is a high-risk pulmonary embolism. I think almost all of us would think this gentleman should be admitted to hospital and observed. I think the question is are there any adjunctive therapies in addition to anticoagulation that might be indicated? Would anyone think about offering systemic thrombolysis to this patient? Normal blood pressure? Not seeing very many arms. Would anybody think about offering catheter-directed thrombolysis? If it's available at your institution? I'm seeing a few hands, yeah. And would anybody say, no, don't thrombolize, just give some low molecular weight heparin and observe in hospital? A few hands for that option as well. It's a tough question. The question of systemic thrombolysis was addressed in the PITHO trial. It's hard to believe, though, that this was published in 2014 now. But they looked at patients like this: high-risk pulmonary embolism, large burden of disease, but with normal blood pressure. And they randomized about 1,000 patients either to systemic thrombolysis with tenecteplase or placebo plus unfractionated heparin. And their primary efficacy outcome of all-cause mortality or hemodynamic collapse within 7 days of randomization, that was prevented in the lysis arm. Interesting. This is old data, and it has not changed our practice. The reason being is because if you break down that composite endpoint, and this trial really highlights the danger of composite endpoints, you'll note that the primary efficacy outcome was not driven by a reduction in mortality, and in fact mortality was the same between the two groups. This was driven entirely by a hemodynamic collapse within the first 7 days, which is not a good outcome, of course. However, I'll highlight the last line there, open label thrombolysis. 23 patients in the placebo arm ended up getting open label thrombolysis, and that just about entirely accounts for the 25 patients who had the hemodynamic collapse. So in essence, we were thrombolysing 500 patients for the 23 of them who actually needed it. So I think the lesson from this trial is that I don't think we should be giving systemic thrombolysis to all patients with big PE, but we should be bringing them into hospital and observing them, because within the first 7 days, around 5% of them may very well crump and require lysis. I'll also point out that in this trial, the bleeding rates in the patients who got systemic thrombolysis were significantly higher compared to the placebo group, including intracranial hemorrhage that was 10 times higher. What about catheter-directed lysis? Well, it's hard to say because there is really no good evidence in this area. I can't present the studies because there are so many kind of small, single-center, crummy ones, unfortunately. They're all typically only a couple hundred patients at most. They're all typically observational and retrospective, and so it's difficult to make any distinct conclusions, but the balance of evidence would suggest that CDT results in a faster resolution of clot burden compared to anticoagulation with low molecular weight heparin, but has been associated with some excess in bleeding. We don't know about long-term outcomes, particularly prevention of chronic thromboembolic pulmonary hypertension, but in the young and healthy patient with a big PE, if your institution offers it, I think it's something to at least consider. And at my hospital, we're actually setting up a CDT center, I think because the evidence is evolving in this, and my own view is that I think it's overall positive. But that's my own view. So teaching point number 3, at this time, the only indication for thrombolysis in PE is hemodynamic instability. And there's no data that supports prophylactic systemic thrombolysis, although CDT holds some promise. Okay, last case in my remaining 3 minutes and 16 seconds. I'm going through these slides quickly, I'm sorry. So this is a 28-year-old healthy woman who's on the birth control pill coming into the emergency room with left leg pain. She's got no history of DVT, malignancy, or importantly, no history of varicose veins. Her examination shows a palpable cord that's above the knee. It's red and it's tender. There's no varicose veins that you can see. The thrombosed vein is not a varicose vein. Her legs are of similar size and her vital signs are normal. So this is phlebitis, is the case that I'm presenting, of course. Who's going to order an ultrasound on this woman to confirm the suspected clinical diagnosis? Yes, I think that ordering an ultrasound is the right thing to do for almost all patients who have thrombophlebitis, and that's to exclude concomitant DVT, which is quite common in this population, perhaps up to 10%. And that would dramatically change management if there's a DVT happening at the same time. Who would offer this woman anticoagulation for her phlebitis that's above the knee in a non-varicose vein? Nobody. Who would offer warm compresses and NSAIDs to a young, healthy person for it? A number of you. Okay, so interesting. I think this trial might change practice. This is the surprise trial. It was a trial that randomized the standard of care, although nobody uses it for superficial phlebitis, which is fondaparinux subcutaneously, compared to a novel oral anticoagulant. And in this case, it was rivaroxaban at a prophylactic dose of 10 milligrams per day. And I apologize for all the data on this slide. They enrolled patients only who were at high risk, meaning the phlebitis had to be at least 5 centimeters long, meaning patients had to be over the age of 65, at least 5 centimeters long, plus an additional risk factor being age over 65 male, history of cancer, history of venous thrombosis, or a SVT in a non-varicose vein. If you see an SVT in a non-varicose vein, that's higher risk for progression than a thrombosed varicose vein, interestingly. And what they found in this trial was that in these high-risk patients, both rivaroxaban at a thromboprophylactic dose and fondaparinux, the standard of care, performed equally well in terms of preventing extension and preventing DVT. However, interestingly what they found, the treatment was for 45 days, interestingly what they found at the 90-day follow-up, so 45 days of treatment, then 45 days off treatment, the rate of recurrence of DVT, of PE, of intervention was 7%. In my opinion, that's an unacceptably high number for a bad clinical outcome. And I think that what this trial highlights is that phlebitis is not necessarily a benign disease, and that we should be strongly considering anticoagulation in patients who are at high risk. So a big thrombosed superficial vein that's above the knee, more than 5 centimeters long, and with any of these risk factors, I would strongly consider anticoagulating the patient, perhaps for 45 days or longer. This is the algorithm presented right off the Thrombosis Canada website and app. I'm not going to go through it because I'm already over time, but the bottom line is that when the clot is long, then anticoagulation is indicated. So, not all SVT needs anticoagulants. The small ones that are distant from the saphenophemoral junction I don't think requires it, but prophylactic doses of anticoagulants probably should be used in most patients who have long thrombosis or thrombosis that is associated with risk factors for extension. So, thank you very much for your attention. I'm going to pass it over to Drs. Strensom and Drs. Mitchell.
Thanks very much, Dr. Bell. I'm going to speak now about the perspective of DOACs in the emergency department from an emergency physician perspective, and then actually we're lucky enough to have a very established guy who's was really the pioneer, one of the pioneers in Canada of electrophysiology and ablations, Dr. Brent Mitchell, who is going to do this with me. We're going to tag team it. Just by way of disclosure, so both of us have significant sort of partnerships with industry. Dr. Mitchell gets grants and research support from Medtronic Canada, and he's on the Speakers Bureau and has received honorary from BMS, Pfizer Alliance, Boehringer Ingelheim, and Servier. Gets consulting fees from these companies, and unfortunately doesn't have any patents, which I can say I do not as well. For myself, I've been supported by all of these companies and this alliance. Speaker fees that I do receive, I put into my research fund, and I don't take personally. And I'm also working at St. Paul's Hospital. I'm not sure if that's worth disclosure or not. So this program has been received financial support from BMS Pfizer Alliance in the form of an educational grant, and the mitigating factors for this are that the evidence we've presented that you'll see today is evidence-based. The recommendations are evidence-based and guidelines-based as opposed to our personal opinions. And the material has been reviewed by the Canadian Association of Emergency Physicians and deemed to be appropriate for this presentation. So what we're going to do, or what I'm going to do, is go through a few cases, and I just want you to think about these cases, because this is, atrial fibrillation is kind of a bread and butter thing that we see in the emergency department. I think most of us are pretty comfortable in treating it and how we treat it. There is, it's a bit of a changing landscape, bit of a moving target, and there are new guidelines that have been produced and some new ones coming down the pipe that we'll talk a little bit about. So think about this. You see a 55-year-old female with a past medical history of paroxysmal atrial fibrillation, no other medical issues, who's got a sudden onset of palpitations at about 11 p.m. Let's say it's 3 a.m. now, and while she's getting ready for bed. She's had DC cardioversion in the past and would like this again. And she last ate or drank 6 hours ago. And you do the cardioversion, it goes smoothly as they usually do. This is her ECG, which Dr. Mitchell pointed out is not actually atrial fibrillation, it's atrial flutter with 2-to-1 block, but management for the most part is quite similar. And what we'd like you to do is to think about these points regarding this case. Should the cardioversion have been done without 3 weeks of anticoagulation in this woman? Okay, I'm not going to ask for a show of hands. I just want you to think about what your answer is, and we're going to address these later on. Should anticoagulation have been given at the time at all prior to cardioversion? Should anticoagulation be given for the month after the cardioversion? Should cardioversion be performed with DC shock or pharmacologically? With DC shock, using what electrode placement and at what dosage in terms of joules? And if pharmacologically, what drugs are you going to use and in what dosage? So how would your responses to those questions change if we change the scenario to say that if it's now a 76-year-old woman? How about if the patient presented 24 hours later? So she said, well, I was hoping it was going to go away, but in fact, I've been in atrial fibrillation all day. So it's now, say, 31 hours. So the second case, I'd like you to think about a little bit different, but still something we see fairly frequently, I would think. 72-year-old male with a past history of paroxysmal AFib, but he does have hypertension, type 2 diabetes, and has had a prior MI. He's receiving sotalol, atorvastatin, losartan, warfarin, and also an anti-diabetic medication. He noticed irregular palpitations upon waking in the morning. He's not sure when it started. He did have an ECG last week with his family physician, which is serendipitous, and as far as he knows, it was normal. He wasn't told that there was anything abnormal about it, but you don't have access to that ECG. He's been unwell for a couple of days with a cough and a fever. When you see him, his heart rate is 110 a minute and irregular. His blood pressure is 102 on 65. Respirate is 24 per minute, and his temp is 38.3, so he's febrile. And his SATs are about 93% on room air. And his INR, when you check it, because he's on warfarin, is 2.8. This is the ECG. Again, it just sort of shows garden variety atrial fibrillation. So we all know about one of the major reasons, or the major reason to anticoagulate people in atrial fibrillation is the risk of stroke. It's a very strong risk predictor for stroke with a relative risk of about 5. It accounts for about 20% of all strokes. The strokes that are associated with atrial fibrillation tend to be big ones. They're not these little lacunar infarcts. They're these large sort of MCA territory devastating strokes. And when you ask people who have had one of these strokes, they often will refer to it as a fate worse than death. The risks are highest with mitral stenosis, mechanical heart valves, and non-valvular atrial fibrillation with CHADS, 2 risk factors. And also one thing is that we should know about is following cardioversion. Okay, so for anticoagulation considerations, we're going to talk a little bit about the 2014 CCS guidelines. Dr. Mitchell's going to speak about this. And I just wanted to point out that 2 things. One is these guidelines are undergoing a new iteration and should be out in the fall in a new form. And there are going to be some interesting recommendations that are still not set in stone. And the other thing is that Dr. Ian Steele, who I think most of us know, he was part of the guideline development process. And one thing in the emergency department is there's nothing worse than seeing a guideline that's been developed by a bunch of specialists, whoever they may be, for use in the emergency department, and emerge docs did not have any input into it. So I think that's sort of a fatal flaw of some of these guidelines, but this does not suffer that because Dr. Steele had a fairly strong input.
So I'm Brent Mitchell. I'm one of those bunch of specialists. I serve on the Canadian Cardiovascular Society Atrial Fibrillation Guidelines Committee. We are in the process of changing the guidelines relative to the anticoagulation recommendations in patients with acute atrial fibrillation. I don't know how it's going to turn out. Ian Steele is not on the committee anymore, so if you want to have personal input, contact Claire at Zima. Sunnybrook and ISIS is where she works. She's the emergency room department physician representative. What I will do today is present to you some new data that is being used by the committee as it thinks about the question of whom with acute atrial fibrillation, that is atrial fibrillation of less than 48 hours duration, should be anticoagulated. The present recommendation, I think you all know well, and it simply states that if atrial fibrillation has been present for more than 48 hours, then such patients need to be prepared for the cardioversion using the well-known 2-3-4 rule. If the atrial fibrillation has been present for more than 2 days, patient needs to be anticoagulated for 3 weeks prior to cardioversion and 4 weeks after. And then at the 4-week point, decisions are made regarding long-term anticoagulation based on the CHADS 65 score that has been promulgated by the Canadian Cardiovascular Society. Of course, you can circumvent this with transesophageal echocardiography, but for the most part, the CHADS score is what's used. Of course, for patients who have had atrial fibrillation for less than 48 hours, the rules are presently a little different. And they say that such people can be anticoagulated without preceding or following oral anticoagulation, provided it's clearly been present for less than 48 hours, and they do not have high risk factors for subsequent stroke, those being a recent stroke or TIA in the previous 6 months, rheumatic heart disease, or a mechanical valve. I guarantee you that come October, this recommendation will change. How much it will change remains to be seen, but we're going to talk a little bit about the evidence. So I hope you all know CHAD 65. It says, ask the question, is your atrial fibrillation patient 65 years or older? That is more than half of the patients. If the answer is yes, oral anticoagulation is required. Second question, do they have any other CHADS risk factors? If the answer is yes, oral anticoagulation. If they have none of those risk factors and are under the age of 65, we ask, do they have vascular disease? If so, they need aspirin therapy, but duh, we would have given them the aspirin therapy anyway, so they probably, that isn't an important decision-making point. And for individuals with none of those factors, no anticoagulation is recommended on the long term. But cardioversion is a different time period, and we're going to talk about that data. Importantly, the Canadian Cardiovascular Society, being a group of physicians, cares about outcomes and has therefore recommended that NOAC therapy is preferred to warfarin therapy for long-term treatment in this circumstance. To me, it is shameful, absolutely shameful, that our payers do not hold the same opinion, except maybe in Quebec, where they've become brighter than the rest of the country, a distinct society. In any event, I'll return to that point in a moment. You all know the CHADS risk factors: heart failure, hypertension, age over 75. Why did we change it to 65? Because CHADS was derived from a Medicare database. Everybody in it was over 65 when CHADS was invented. So to identify a higher risk profile, the age had to be higher than 65, and indeed it turned out to be 75. Subsequent databases have taught us that we should have used 65, so that's why CHADS is now CHADS 65. And it's important that you recognize that the original definitions of each of those components has changed. In particular, I draw to your attention that heart failure is not, as it was in the beginning, an admission to hospital with heart failure. It is now also signs and symptoms of systolic heart failure, where a decrease in left ventricular ejection fraction is assumed, a moderate to severe reduction in left ventricular ejection fraction on imaging, or any admission for heart failure, even if it's diastolic heart failure. The other one that's changed significantly is stroke. Stroke was originally stroke. It is now stroke, TIA diagnosed by a neurologist, systemic thromboembolism, or even pulmonary thromboembolism for, in these patients, those with non-valvular atrial fibrillation, the source of the pulmonary embolus could be the right atrium. Now, in preparation for talking about acute atrial fibrillation, I want to remind you how that score was created. In the Danish database, there are 73,500 atrial fibrillation patients, and so you can identify the relative risk imparted by any single measure of clinical characteristic. So the CCS said the risk of oral anticoagulation, no matter how well guided, is about 1.5% per year for a major hemorrhage. So the risk of the stroke you're trying to prevent damn well better be higher than that. If we look at age, this is prior stroke as defined in the new guidelines. That relative risk is 8 times higher. That's why it's obviously a risk factor. Age greater than 75 years, 4 times higher. Age greater than 65 but less than 75, 2 times higher. Heart failure, 2.5 times higher. Hypertension is actually the weakest predictor that is presently used in our algorithm, but it did make the predefined cutoff of 1.5% per year. Diabetes did too. Vascular disease did not. And that is why the Canadian Cardiovascular Society does not use CHADS-VASC. And especially female gender as a singular risk factor is not a risk factor at all. It does become a risk factor in the elderly. However, we've already identified the elderly as people who need to be anticoagulated. And so that's where CHAD 65 came from. One thing that is hidden from you, though, is what if you're female and have vascular disease? That group does make the cutoff, but the Canadian Cardiovascular Society guidelines are silent on it. I personally, this is a personal opinion, we're supposed to announce them when we have them, recommend anticoagulation for young women with vascular disease. So that's how the CHADs came about. If we are to ask in the acute setting, is there any evidence as to whether we should be using warfarin or should be using NOAC to prepare a patient? Here is an analysis that looks at the 4 pivotal trials of the current NOACs and 2 trials that were randomized clinical trials of a NOAC versus warfarin in preparing a patient for atrial fibrillation cardioversion. XVERT and ENSURE. Dr. Renda did a meta-analysis, which is shown there with the bottom dot, saying that there was nothing to choose between these drugs in terms of 1 month of therapy to get, 7 weeks of therapy to get a patient ready for a procedure called cardioversion. But more recently, the apixaban randomized trial called EMANATE was published, and it showed a massive improvement with a NOAC compared to warfarin, but it was not statistically significant. Nevertheless, this was not included in the meta-analysis described by Renda, so I did one for you. That's called My Chi-Square of XVERT, ENSURE, and EMANATE. And depending on which statistical test you use, you can come up with something very close to a statistical benefit in preparing a patient for cardioversion using a NOAC rather than using warfarin. The monthly risk after a cardioversion, shown here on the left side for patients who have been in atrial fibrillation for more than 48 hours, comes from a Danish database. It's 0.79% in the next month for a patient who has been in atrial fibrillation for more than 48 hours but is not receiving an anticoagulant. Such cardioversions are apparently done in Denmark. Beside it is patients who received an oral anticoagulant prior to their cardioversion, and you can see a substantial reduction in the risk of stroke over the next month. What is shown in the darker blue is data from the FIN-CV study, which shows the same data for patients who have been in atrial fibrillation for less than 48 hours. And I would suggest to you that the light blue bars and the dark blue bars look terribly familiar, yet we are similar. Yet we treat these 2 groups of patients completely differently. I suggest to you that we are likely not to treat them completely differently in the near-term future. That is shown on the red line there is the 1.5% annual risk accepted by the Canadian Cardiovascular Society as the threshold for oral anticoagulation. And you will see that some patients who have been in atrial fibrillation for less than 48 hours exceed that risk, and I expect that the new guidelines are going to impact your practice because we're going to pick away at some of them. Here is shown those 2 risks, that is risk on an oral anticoagulant, light blue, off an oral anticoagulant, dark blue, for patients presenting in less than 48 hours in Finland, based on their CHADS VASC score, which is of course very popular in Europe. And you can see after a CHADS VASC score of 2, we have to ask the question, why are we not anticoagulating these people? You can look at it another way. If we look at individuals who are cardioverted after less than 12 hours versus more than 12 hours but less than 48 with our line in the sand, we have to ask the question, are we sure we want to be anticoagulating people who have been in atrial fibrillation, are not anticoagulated, people who have been in atrial fibrillation for more than 12 hours. These are the points that are being pondered right now by the Canadian Cardiovascular Society. I said I would return to this point before. We all know that at least some of the NOACs are safer than warfarin. We now know that at least some of the NOACs are more efficacious than warfarin. We know at least one of the NOACs, apixaban, is both. Why are we not using it in absolutely everybody? The answer is economic. But if we look at the quality adjusted year of life saved with NOACs over warfarin in this setting, they are all actually cheaper than warfarin. The problem is the cost savings comes out of one budget and is expended in another budget. And we can't seem to get our provinces to think holistically. Now some rate and rhythm control considerations. You're back on.
So one thing that's interesting about this is that, you know, when we think about a patient in front of us in the emergency department, we want to know things like how long they've been in atrial fibrillation. And we've traditionally used the 48-hour cutoff, but that, if you look historically, has been based on some really weak evidence from over 40 years ago, and it was sort of a theoretic thing that, yeah, 48 hours is or less is fine, more than 48 hours is not okay, and there's not really a good basis for that. The other thing we want to know about is any underlying medical illnesses sort of beyond CHAD. So what I'm talking about is acute medical illnesses. And this is actually a study that was done at St. Paul's by Dr. Frank Schurmeyer, who's done a number of studies in this area. And it basically shows that if you take someone with underlying medical illness, so something acute like pneumonia, sepsis, heart failure, something like that, and you try to either rate or rhythm control them, things go badly. So, you know, the adverse event rate, if you see there in the darker yellow, is quite high. And the success rate for rate or rhythm control is actually quite low. It's about 20%. So in certain situations, when this person has been driven into atrial fibrillation by an underlying medical cause, you do not want to do anything except treat the underlying cause. So, you know, fluid resuscitate them, give them antibiotics, whatever it may be, depending on what the offsetting problem is. But you need to be really careful when you think about intervening just on what's in front of you, the rate or the rhythm. And this was done with a propensity matched analysis, which did not change the results. So this one, you know, for what we're going to do for transthoracic DC cardioversion, I think most of us are pretty comfortable with that. Sedation with whatever you use for sedation. So it's going to be in a consenting patient in a post-absorptive state who also does not have digitalis intoxication, pretty rare these days, but happens now and again, or hypokalemia. The procedure is going to be performed under, for us in the emergency department, deep conscious sedation, procedural sedation we're calling it now. We're going to use AP lead placement, and we're going to use a biphasic waveform. I think almost all of the defibrillators use biphasic now. And we're going to be delivering QRS synchronous shocks with an escalating stored energy protocol from 200 joules. So I mean, certain protocols in the past have suggested 100 or 150 or starting lower in atrial flutter, but as Dr. Mitchell mentioned, he said, I'd rather just do it once with 200 joules as opposed to starting off at 100, then going 150, then 200. So the success rate is greater than 95% most of the time. And VT or VF is in 1% of patients. I mean, I've never seen it, and knock on wood, hopefully never will, and that's probably due to people forgetting to synchronize the waveform. You get an R on T. And CHF decompensation happens in 1% or fewer. So it seems fairly safe. A couple of studies, you know, a big outcome now, certainly in emergency department studies with emergency department overcrowding, is length of stay. So, you know, if someone ties up an acute bed for 10, 12 hours, you know, that's sort of a missed opportunity for your person sitting out in the waiting room with undiagnosed chest pain. So, you know, ED length of stay is becoming more and more an outcome that's important to us. There was a study done back and published in 2012 where they looked at 250 patients in Italy, and they compared DC cardioversion to 2 milligrams per kilogram of IV propafenone, which is not really a thing in Canada that we use. One thing that I thought was interesting, just as an aside, was that bedside cardiography, echocardiography, was done by the emergency physicians who were trained, and they actually got pretty good at it in terms of looking at systolic function, valvular issues. The success rate was about 90% with DC cardioversion versus 75% with IV propafenone. The median length of stay, as you would expect, was much lower. It was like a third the time, or almost a third the time for people who got DC cardioversion, and they were sent home. Again, Dr. Frank Schurmeyer has completed a study. It's not published yet, and I can't say too much about it, but where he randomized people to a strategy where they got either got chemical cardioversion first or DC cardioversion first. It's like I said, it's not published, but it was, as you would expect, again, that the DC cardioversion patients were out of the emergency department a lot quicker.
I think it is true that the only time DC cardioversion ends up with VF, hardly ever VT, is when the shock was not R-wave synchronous. Just to make sure everybody knows, I think you probably do, but the cardioversion machines that we have, after supplying one shock, automatically switch to asynchronous cardioversion. In case the next rhythm was VF, it doesn't have to be sensed in order to deliver a shock for the treatment of VF during a state of panic. So if you're going to give 2 shocks for the treatment of atrial fibrillation, it's critical to remember you have to resynchronize the machinery, or you will be delivering asynchronous shocks the second time. We're often asked, well, what drugs are good if we want to do pharmacologic cardioversion? IV flecainide has been a favorite in the United States and Europe, not so popular in Canada, largely because we can't have it. But because of its popularity, it has been compared in randomized clinical trials to most other agents. And because of the use of a single common comparator, it is then possible to do a network meta-analysis and estimate the relative efficacies of each of the drugs because they were all compared to the same thing. And that's what this slide shows here, that IV flecainide has a success rate of conversion of acute atrial fibrillation or flutter of about 66%. Second is ibutylide, 59%, most effective for flutter rather than fibrillation. Propafenone at 46%, but that's IV propafenone. IV procainamide around 44%, IV sotalol around 29%, and IV amiodarone around 25%. If we take away the ones you can't have, then these are your choices. At present, I'm told by those who practice in the emergency department that ibutylide is not commonly used, and we'll see why in a minute, and that the favorites are procainamide and amiodarone, being the only 2 remaining agents. I draw to your attention, though, that amiodarone is certainly the most effective. It's just that it takes 2 or 3 days to get there, and therefore is not particularly attractive to emergency room physicians. These are 2 studies that compared the placebo conversion rate in gray to the active IV amiodarone conversion rate in brown in 2 different studies, and you can see that it takes a long time to get there with amiodarone. Nevertheless, the beta blocking effects of amiodarone are very quickly established. So I do recommend it highly as a rate control agent in the emergency department. Also draw your attention to a new drug on the market. This was invented by Cardiome in British Columbia. For a while was being investigated by Merck, but Merck decided to get out of the anti-arrhythmic drug market. But this is a drug that's given as a bolus and then an infusion, and converts 52% of acute atrial fibrillation patients in a median time of 11 minutes, and Torsad has never been reported. It's a drug that you might want to look into. About the only area that I avoid its use is in patients with congestive heart failure. Ibutylide is still an effective drug, but the reason I think it's less used is its success rate is lower, and Torsad occurs in about 9% of the people given the agent. So we routinely pre-medicate such people with magnesium sulfate, and that in itself may actually decrease the efficacy of the drug. But how are you guys doing? You're doing really, really well, but I'm going to make one point, and that is because you're already selecting low-risk patients for acute intervention in the emergency department, as will be discussed by Rob.
Yeah, so we're almost done time-wise, but these are actually data that were published in 2010, 2011, I believe, and so basically we're looking at data that's over 10 years old by the time it was collected. So, and the point is, as Dr. Mitchell said, that we're actually doing okay. We're actually doing quite well in terms of looking at our patient population and carefully selecting those who, A, can be cardioverted, and B, can be sent home. And again, this is a study done by Frank Schurmeyer. It basically showed that in these patients, there was over 900 of them, that their event rate was actually very low in terms of anything happening untoward, either strokes or deaths in the first 30 days, if we sent them home. There were seven deaths, I believe, or 5 deaths, 2 strokes. All of those patients were admitted at the index visit, meaning that we as emergency physicians recognize that these are sick people, not people safe to go home, and so they got admitted appropriately. So in conclusion, you want to join me up here for these, Mitch? Okay. So atrial fibrillation and flutter are strong risk factors for strokes, and they tend to be large strokes, as we mentioned, commonly affecting the MCA territory. The month after cardioversion is a high risk period for stroke, which is something that I think as emergency physicians maybe we don't appreciate all the time. Following attempted or successful cardioversion, antithrombotic therapy should be initiated as per the CCS algorithm that we spoke about. Long-term anticoagulation is recommended by the CCS guidelines for patients with CHAD 65 greater than 0, and NOAC is advised over warfarin for non-valvular AFib patients. Current CCS guidelines permit cardioversion of acute atrial fibrillation or flutter within 48 hours without anticoagulation in low-risk patients. That may well change come October when these new guidelines will come out, and I think it behooves us to follow these guidelines. And as Dr. Mitchell was saying, there is an emergency physician, Claire Estima, who's on this board. DC cardioversion is appropriate, in the appropriate patient is safe. It decreases ED length of stay, and it has a higher conversion rate than chemical cardioversion. And that is it. Thank you.
Great discussion. Thanks, guys. So, because we do believe that old docs rule, we have microphones. Please ask questions. For the new docs, there's also hashtag CAEP2018. Please feel free to ask questions of the panel. While we are waiting for the questions to come, a quick question for Ben. Ben, thanks very much. By the way, I really want to make a plug for Thrombosis Canada. For those of you who haven't used it and do carry your phone around, download the app. It's a free app. You have point-of-care clinical decision aids, a lot of the stuff that Ben talked about with regards to superficial venous thrombosis, your PE risk stratifications on there that you can help make decisions in real time. Ben, can you talk to a little bit about below-knee DVTs, both with regards to diagnostic follow-up algorithm and treatment?
Thanks for that question, Indy. Oh, is this working? Thanks for that question, Indy. Yeah, so a couple of things with distal or below-knee DVT. I think first off, it's really important to know what kind of scans you're getting at your institution. You need to know if you're getting whole leg or partial leg ultrasounds. And that's because a patient can come in to your hospital with leg swelling, pain, redness, look like a DVT. You do an ultrasound and it's read as negative, but that could be because it was only looking at the popliteal vein and higher. Is there a clot below the knee? And so in the high-risk patient in whom you only have a proximal leg ultrasound, you need to do something else. There has to be some clinical follow-up in terms of that patient. In particular, most guidelines would recommend follow-up ultrasounds at 5 to 7 days on 2 occasions to make sure that there's no proximal propagation of a distal DVT that was missed. You could consider checking a D-dimer and a partial upper leg ultrasound in combination with a negative D-dimer effectively rules out DVT, or you could simply ask your radiologist to do a whole leg ultrasound if you think the pretest probability is high. But it's really important that you don't send these patients home with reassurance and no clinical follow-up, because something is definitely required in the case of patients who have just upper leg scans that are done. In patients in whom you find a DVT below the knee, I think there's a lot of discussion in the literature and amongst experts as to how these patients are best treated. My own practice is because if you're not treating a distal DVT, so much follow-up is required. My own practice is to recommend anticoagulation for most patients unless their bleeding risk is high. But if you want to risk stratify such patients, a distal DVT in combination with a positive D-dimer, in combination with cancer, severe symptoms, a history of venous thrombosis, if it comes on in an unprovoked manner, or if it comes on because of a persistent risk factor, for example, the patient's leg is still casted, then those patients are all at high risk of propagation and generally speaking should be treated. It's the patients who are at low risk and whom you could consider not giving a 3-month course of anticoagulation to.
Thank you. There's a question here.
Great presentation. I was just recently in a conference in Florida and they're talking about atrium appendages occlusion or ablation. What is the future and can you comment on that? This is in regards to atrial fibrillation management.
So it appears that the majority of thromboembolic events that occur in people with non-valvular atrial fibrillation are related to clot formation within the left atrial appendage. So if the left atrial appendage didn't exist, it was argued that the thromboembolic risk would be dramatically reduced. There are ways to do that surgically. You would think with almost 100% success. Astonishingly, actually with much lower success. Apparently it's very difficult to isolate a left atrial appendage, but of course it could be excised with nearly 100% success. Accordingly, there is a randomized clinical trial going on as we speak, wherein people going for cardiac surgery for any reason are being randomly assigned to have excision of their left atrial appendage versus not. And we'll have the answer in a few years. Meanwhile, there are also technical ways to do that transvenously, and one that can be done transthoracically, where the left atrial appendage can be closed without actually subjecting the patient to cardiac surgery. The randomized trials of that procedure that have been performed suggest an efficacy similar to that of warfarin. The procedure has not been compared to NOACs, but has been compared to warfarin. So it is being used as an adjunct mostly in individuals who cannot take oral anticoagulation, usually because of gut bleeding. Does that answer your question, sir?
Any other questions? Oh, Dr. Mincer.
Okay. Hi, thank you. Excellent presentation. Just a question, I guess, for Dr. Mitchell. In the 2014 guideline set where the energy level for biphasic DC cardioversion was increased from 120 to 150, part of that rationale was on, I believe, the very rare risk of converting it to VF. Just wondered if that might contribute to the VF incidence you were referring to earlier.
Interestingly, I doubt that it had anything to do with it. I can't remember that discussion in particular, so I can't explain it. But it is true that the lower energy that is used, the higher the probability of VF if it hits the vulnerable period of the T wave. So you can induce VF on purpose, and we actually do that when we're testing defibrillators, with low energy shocks around the T wave. But if the energy of that shock is high enough, it doesn't matter where you place it, it won't induce VF. So it's actually less VF induction with higher energy waveforms.
Right. And so in your presentation, you used an example of 200 joules. Do you see the number of 150 then increasing at all?
I can tell you that in the discussions that we've had, that question has not come up, so I doubt that it's changing. The CCS Atrial Fibrillation Guidelines Committee did the whole thing back in 2010, and since then have updated little packages each year. This year's package does not include the cardioversion question.
And finally, do you think that we're not anticoagulating enough after DC cardioversion in the emergency department setting?
Yes. And the guidelines, I predict, will change to encourage it to happen more and to encourage it to happen by the emergency room physician.
Thank you.
Perfect. And just perfect segue to that. There is a study out of Spain, I think our panel presented it last year, called the Emerge AF study. Those of you who haven't looked at it, it's on, I don't know if you can, the AV guys can put it up on the screens. But this study basically was a multi-center, over 62 Spanish emergency departments over 1 year they followed and looked as prospective, observational, and they looked at prescribing anticoagulation from prophylaxis in people with atrial fibrillation. And basically at 1 year follow-up, there was no increased risk of major bleed. And this study is in the setting of Spain, which we know is one of, if not the highest, users of warfarin, not DOACs, in North America and Europe combined. So in that patient population, high warfarin use, 62 emergency departments, over 1,100 patients, no higher risk of bleeding in people selected for stroke prevention and fibrillation. So presumably, you would imagine using DOACs, doesn't matter which one you pick, the rate of bleeding should be lower. One last question.
Great, thank you. My question is about valvular atrial fibrillation. And as an emergency physician, what are we supposed to do with those patients with respect to NOACs? Because the literature is always on non-valvular AFib.
So valvular atrial fibrillation patients are those with a mechanical heart valve or those with moderate to severe rheumatic mitral stenosis. All other valve lesions are called non-valvular. So atrial or mitral insufficiency, no matter how severe, is still called non-valvular. It's just those two. Those two were excluded from almost all of the clinical trials because at the time these clinical trials were being done, it was argued that it was unethical not to give warfarin to a person with a mechanical valve or rheumatic mitral stenosis. So the trials routinely excluded them, so we don't know what to do with them. The exception was there was one trial that compared high-dose dabigatran to high-dose warfarin for the treatment of mechanical valve, and warfarin actually won both in terms of efficacy and in terms of safety. So those people get warfarin. It's that simple. If you're really keen, we recognize that it takes a while to get warfarin therapeutic. So then the option exists to use low molecular weight heparins until you get there. And I would do that, especially for a mechanical valve, if you found one that wasn't anticoagulated.
Thank you.
I'd like to thank everyone for attending. All of those of you who stayed really late. On your evals, as you fill them out, please feel free. If you think there's any other questions or cases that you'd like us to address next year, if there's specific things that you wanted in terms of content delivery or style, please let us know. We really do use that. Thanks again very much, and thanks to CAEP again.
Thank you, Dr. Ghosh. I'd like to echo thanks and just to reiterate the need for evaluation. So please do fill out the evaluations. We really do appreciate your insights. And I want to thank all the speakers for a very impactful discussion around atrial fibrillation management, anticoagulation in the emergency department. Thank you all.